Welcome to ATCM, the Emergency Medicine Channel.
Yes.
A 74-year-old female was brought to the ER with complaints of decreased response since last 4 hours. On initial assessment, airway was patent. There was no secretion or gurgling of sound. Breathing-wise, bilateral air entry was there with the respiratory rate of 20 per minute, saturation 100% room air. Circulation-wise, BP was 160/80 with a pulse rate of 70. Disability-wise, GCS was E3V4M5. Pupil bilaterally equally reactive. Exposure-wise, temperature was 98 degree Fahrenheit with a GRBS of 34 milligram. At this point, sir, we inserted one large bore cannula and started the patient with 25% of 100 ml dextrose. After that, patient's sensorium improved, and then we started her on IV fluid DNS on maintenance, and repeat GRBS was checked, which came to be 280 milligram, and she was kept on hourly monitoring till her sensorium improved and she was able to eat orally. So coming to sample history. 70-year-old female brought to the ER with complaints of decreased response since 2 a.m. in the morning. She had history of feeling generalized tiredness, decreased appetite since evening. She had not even consumed her dinner. There is no history of any deviation of mouth, any vomiting, involuntary micturition, fever, or any one-sided weakness. Coming to allergy history.
Can hypoglycemia produce all these things?
Yes, sir.
Hypoglycemia is one condition which can mimic any stroke. Okay, paraparesis, quadriparesis, everything can be reduced, like not able to talk. Everything can be produced.
Coming to allergic history, she is not allergic to any known medications. Medicine history, she is on tablet ecospirin, clopidogrel, amlodipine, metformin, glimepiride. Past history, she is a known case of diabetes, hypertension, and coronary artery disease. Last meal, she had last consumed her tea at around 4 p.m. in the evening. Dinner she had not consumed. Then coming to systemic examination, all systems were within normal limits. After giving dextrose 25%, her sensorium also improved. GCS was full 15/15. She was recently admitted in our hospital 5 days back with a history of UTI at that time, after which she was discharged. Urine culture was sensitive to Klebsiella at that time. She was treated with phosphomycin and she was discharged. Following which she did not have any complaints of any fever or anything. This time, first event of hypoglycemia, considering it secondary to glimepiride, because she is taking her OHs, metformin and glimepiride, but she did not consume her night dose of night dinner also, but she had taken her medication, sir. So drug-induced hypoglycemia, provisional diagnosing it to be a drug-induced hypoglycemia. So we admitted the patient, we stopped her.
What is the problem of glimepiride? This is glimepiride or glycoside?
No, glimepiride.
Glimepiride. What are the problems of glimepiride?
Basically, sir, glimepiride will be long-acting. Even after we stop the drug, patient has chances of going into recovery.
Among sulfonylureas, this is one of the safest drug. It does hypoglycemic episodes are low comparing with your glycoside, glibenclamide and all. Glibenclamide is most notorious. Okay, but even then, the duration of action is very much prolonged. Okay, it may be more than 24 hours. Okay, so we have to be very careful.
So we admitted the patient. We did 1 hourly monitoring of the patient. Then the patient did not have any more hypoglycemic episodes after that. Then patient was monitored for 1 day. After she improved, she was discharged with only metformin. Glimepiride was withheld, sir.
Metformin can produce any complications?
Metformin
can it produce hypoglycemia?
That commonly, sir.
Theoretically, it is no. It is only a insulin sensitizer. Very rarely it can produce hypoglycemia. So normally it will not produce hypoglycemia. Any other side effects of metformin?
Lactic
acid. How many cases you have seen?
LFT derangement.
It is clinically not. Metformin was the primary drug used to produce lactic acidosis. Then it was changed to metformin. The incidence of metformin-induced lactic acidosis, even in liver failure patients, we are seeing patients. We are supposed to stop it, But lactic acidosis is very, very rare. Unless until you take large dose of metformin by suicidal intention, then only it can produce lactic acidosis. Normally, we don't see any lactic acidosis in metformin at all. Common side effect is
Weight loss.
weight loss is not a side effect; it's an effect of metformin. We use
LFT derangement.
gastritis is the most common side effect of metformin. To avoid that, what we can do? We can give extended release tablets. That can, some extent, it can avoid that gastric irritation. Okay, metformin can produce weight loss, so we should be very careful in which type of patients. It can produce early satiety. It can produce early satiety and weight loss. So, which type of patients it is indicated? Which type of patients you should avoid?
Obese patients.
Obesity, it is indicated.
PCOD indicated.
PCOD, it is indicated. Which type of patients we should avoid it?
Lean
Hmm?
and thin.
Thin patients. Thin patients, it is not going to work. It should be avoided in elderly individual. Elderly individual already, they may not have taste for food, so they may not be taking food. On top of that, if you give metformin, again their satiety will come down and they'll lose weights. Lot of adverse effects can happen. So we should avoid that. Okay.
Coming to the causes of hypoglycemia. It could be one of the causes could be drugs. It is due to insulin or any insulin secretagogues. Then it could be due to alcohol. Then it could be due to any critical illnesses. Which could
What are the other drugs which will produce hypoglycemia?
so quinine
Quinine can produce.
Then gatifloxacin.
Gatifloxacin. Previously it was in use, but because of the hypoglycemic effect, it was removed. Quinine is the most important drug.
Then sir, other critical illnesses, if patient is having any hepatic renal dysfunction or if patient is in sepsis, the patient can go into hypoglycemia, spontaneously hypoglycemia.
Malaria?
Malaria patient can go into hypoglycemia. Then sir, if there is any hormone deficiency such as sir, cortisol, any growth hormone deficiency or any glucagon or epinephrine deficiency. Then sir, patient can also endogenous hyperinsulinism if it is due to any insulinoma. Any functional beta cell disorders, that nesidioblastosis if it is there. Then any insulin autoimmune hypoglycemia can be there. And then sir, any disorders of gluconeogenesis or fatty acid oxidation or due to exercise induced hypoglycemia.
Where you get postprandial hypoglycemia?
And that is post gastrectomy patients. Due to
normally you can get some you can see some patients come with postprandial hypoglycemia. Post gastrectomy is very classical. Spontaneously they develop hypoglycemic symptoms.
So due to sir, some causes are due to
one is like you told, insulin antibodies can produce sometimes this problem. Insulin antibodies. Then
the congenital disorders of glycosylation, they can also.
So there is a condition called as postprandial hypoglycemic episodes. Okay, what happens is when you take food, there will be acute surge release of insulin. So before the food enters or the glucose enters to your body, insulin might have released. So that sometimes produces hypoglycemia after the food. Okay, so this is called as postprandial hypoglycemic episode. These patients are prone to develop diabetes after some times. Okay.
Then sir, basically her first response wise, our first response to hypoglycemia is insulin. That will be the primary glucose regulatory factor. After that, the second defense against hypoglycemia is glucagon. First insulin and after glucagon, and after that the third defense will be when glucagon is deficient.
When there is hypoglycemia, insulin will...
No, insulin will reduce. Like first,
insulin will reduce.
Hypoglycemia, patient, first response will be decrease in insulin secretion. Second response will be increase in glucagon production.
So can we use glucagon in all hypoglycemic patients?
In all if we can use patient, basically if we don't have an IV excess, we can give insulin.
What is your opinion? As emergency doctor, what is your opinion?
If you try to correct the GRBs, then it's not increasing.
But it will take at least 15 minutes to walk.
So previously it was told only persistent hypoglycemia you have to give glucagon. But now current guidelines is you just give glucagon. Because we don't know whether we are going to get the IV lens. We don't know whether we have adequate staffing. If you have everything controlled environment like this, you can do it. But suppose you are practicing peripherally, you are not able to get a line. Glucagon is the best option. You give glucagon, patient will improve.
Around 15
Cost
minutes.
wise, it is double, but as a
Action
guidelines, it is
onset
not, they are not telling the cost. But in our country, cost is very high. Glucagon is very costly. That is the only issue we are facing.
Onset of action will also be prolonged, around
Slightly delayed.
7 to 15 minutes it will take. Then sir,
So this happens only when you have a patient who is developing repeated hypoglycemic episode. He is managed at home, and the person who is taking care itself can give glucagon. So that is the advantage. No need of IV line. Nothing is required.
and then so the third difference will be increase in epinephrine when glucagon is deficient, and fourthly it will be cortisol and growth hormone that is usually seen in prolonged hypoglycemia. Only after
What is
around
the
4
dose of
hours.
glucagon?
1 mg, sir.
1 mg. Where else it can be used?
In beta blocker toxicity we
Where
can
else?
use.
Any other?
Calcium glucose.
Calcium
So
channel
both
blocker
beta
toxicity.
blocker and calcium channel toxicity can give glucagon.
Then that sir, we can also have sir spontaneous hypoglycemia. That is when a patient in a non-diabetic patient, when patient goes into suddenly hypoglycemia, then we term it as spontaneous hypoglycemia.
In that condition, which investigation will send?
So we have to send for insulin and C-peptide in that
Serum
patient.
insulin level and serum
C-peptide.
C-peptide level. Okay. So most of the time we don't see all this is a problem. Most of the time we'll miss the diagnosis. A patient come with hypoglycemia. If you have taken history of like tablet or insulin, then mostly we no need to do it. Suppose he has come without any history of hypoglycemic tablets or insulin, first investigation to be taken is insulin level, serum insulin level. So in acute hypoglycemic episode, normally if the serum insulin levels are very high, then you have to suspect insulinoma. Okay. So what is the triad called as?
So Whipple's triad.
Huh?
Whipple's triad.
Whipple's triad.
Triad in
What is the triad? It is not Whipple's triad. Something else. Correct. Whipple's triad.
that symptoms of hypoglycemia
yes,
should be
correct.
there. Then GRBA should be less than 50 and
Okay.
the symptoms should resolve after giving
Okay.
correction.
Whipple's triad.
Whipple's
Okay.
triad.
So that indicates
Insulinoma.
insulinoma. Mostly it is insulinoma. You have to check the insulin level and C-peptide level. Insulin levels will be very high and even C-peptide levels also will be very. Suppose the patient had taken insulin like suicidal intention. Suppose a doctor takes insulin, come back with hypoglycemia. You don't give the history of insulin intake. How do you diagnose it?
Then serum insulin levels will be very high
Very
because it
high.
is exogenous insulin, but the C-peptide levels will be normal.
Normal. That is a difference between a exogenous insulin and endogenous insulin. C-peptide also will be high in endogenous.
Endogenous.
C-peptide and insulin level. Whereas if, externally if you are taking only this one will be high. Insulin level will be high.
So, sir, then sir, symptoms of hypoglycemia we will have to divide.
If the patient is on insulin, what are the conditions? Like he is taking 10 units TID, like for an example. What are the conditions in that patient can precipitate hypoglycemia?
Sir,
What are the common problems we are going to face?
one, if he skips his meal after taking the dose,
Okay, if he is not taking any meal after taking the dose.
then if dose error is there, if he takes increased excess dose in his comparison to normal.
What are the problems of what are the scenarios you can get a dose error? Like you are taking every day 10 units. How can it change? Every day you are taking 10 units. What is a common problem in our country? These are the common problems you should know. What do you do then? You take that insulin syringe. That is most important. You take that insulin. There are two types of insulin syringe available in our country. One is
Intradermal.
this is a problem.
Intradermal.
10 division mark.
What is that 10 division mark? Everything is 10 division.
Tuberculin syringe.
One is 1 ml contains 40 units. Another one is 1 ml contains 100 units. So that you should know. A person who is taking 1 in 40 should take 1 in 40 insulin syringe only. A patient taking 1 in 100 units insulin, he should take only in 1 in 100. The problem is sometimes if you change the insulin syringe, then the total dose itself will become sometimes double. Okay, so this is the most common error made by most of the patients. It is not a error produced by the doctor. It is error produced by the patient. They purchase 1 in 1,000, 1 in 100 units insulin, or sometimes 1 in 40 units. Okay, so that can sometimes create a big issue. Okay, so you have to see that. Then third one.
Patient renal failure. If patient has gone
Renal
into
failure.
renal
That is
failure.
a common scenario we come across. Say, if the creatinine is increased when we give the same dose of insulin, it will become an extended releasing or extended action spectrum insulin. Okay. Which are the types of insulin can produce hypoglycemic episodes? Is it short acting or long acting?
Short acting.
Short acting insulins are more prone to develop
hypoglycemia.
hypoglycemic episode than long acting insulins. Okay. What is the action of quinine?
So quinine is actually insulin secretagogue. It
Secretagogue.
will increase the release of insulin.
Okay.
That is,
So how do you give quinine? Have you given quinine any time?
in dextrose.
Nowadays we are not giving quinine because of its arrhythmias. How do you give quinine?
Yes, give in continuous dextrose infusion.
So it has to be continuously infused in dextrose, and even after quinine dose, you have to continue the DNS. So two things we have to take care of. Okay, but nowadays we are no need to worry because we are not using quinine. Maybe some areas where other drugs are not available, we are using quinine. Okay, anything else you want to tell us?
The symptoms of hypoglycemia we have to divide according.
What are the symptoms of hypoglycemia?
Symptoms are basically divided as adrenergic, that is adrenergic symptoms, and one neuroglycopenic symptoms.
Okay, what are the
Neuroglycopenic symptoms will be seen basically confusion, sweating, then will be headache will be there, seizures, mental obtundation over a prolonged period of this
Other
thing.
one?
And then adrenergic will be mostly acute symptoms. That will be sweating, tachycardia will be there, palpitations.
Which one occurs first?
Headache,
These are the
neuroglycopenic will occur.
Adrenergic symptoms are the fastest. Okay, that's why beta blocker has got some problem here. So when the patient is on beta blocker, like most of our diabetic patients are on beta blockers, these symptoms are masked by beta blockers.
Yes.
So they suddenly go to comatose state. That is a problem of beta blocker. This is called as
Hypoglycemic
unawareness. So they are not aware about hypoglycemia. Suppose the patient is not on beta blocker, they will come to know that I am going to develop hypoglycemia. So they can do something. Okay, but this patient suddenly go to hypoglycemia. That is the only issue. What are the clinical differences between hypoglycemia and hyperglycemia? Is there any clinical difference? It will be very difficult to identify clinically, but sometimes you can.
hypoglycemia. So
Hypoglycemia and hyperglycemia both can produce unconsciousness.
So hypoglycemia will basically this
You already told
hypo-
the answer. What are the answers?
tachycardia.
Tachycardia is mostly
Tachycardia and sweating will be seen in hypoglycemia.
that will be just
Dehydration.
normal or reverse in other condition.
But here it will be dehydration will be there, and if it is
Okay.
hyperglycemia,
Okay.
then oliguria, thirst will be there. Patient will be very thirsty. Then
Acidotic breaths are
acidotic
more
breath in
common.
hyperglycemia. Their pulse will be weak. Kussmaul's breathing, BP can be on the lower side.
Okay.
But on hypoglycemia, BP and pulse usually are normal. Breathing pattern is also normal. And that if we come to blood examination, pH level will be normal in hypoglycemia, but in hyperglycemia, pH will be low. Ketone bodies will be present.
May be present.
In blood, and then decreased
But
history.
clinically, even when we are telling all these things, clinically it will be very difficult to make out whether it is hypoglycemia or hyperglycemia. So what advice you give to your patients? Patient is telling, I am getting repeatedly hypoglycemia, sometimes it is hyperglycemia. So we don't know whether the patient, patient bystander may not be knowing whether it is hyperglycemia or hypoglycemia. Whatever we tell all these textbooks. So what advice you give? Suppose somebody become unconscious at home, who is on tablets.
Sugar solution.
Better to give steroids. So you should know which is more dangerous, hyperglycemia or hypoglycemia. Which is more dangerous?
Hypoglycemia.
Hypo is always dangerous than hyperglycemia. So whenever suppose somebody become unconscious, you don't need to check whether it is hypo or hyper. Just give sugar, because if the hypoglycemia persists, what will happen? Persists for some time. What will happen?
So brain cells.
Brain cells can get damaged. Like your hypoxemia in cardiac arrest, more than 3 minutes, if the brain is not getting adequate glucose, it normally produces a problem. That's why we treat Hypoglycemia more vigorously than hyperglycemia. Hyperglycemia, you have time, you can treat, nothing will happen. But hypoglycemia can produce permanent damages. Repeated hypoglycemia, any changes in the hand you can see? Repeated hypoglycemic episodes. You can see most of the patient's hand will be wasted. The hand will be, you can see in the diabetic patient. That is a sign of, due to some reason, that is a sign of repeated hypoglycemia. Okay. So many patients you can see. Okay. Okay. Thank you.